Hello, I'm Dr. Alice Liang. I'm the moderator of these child and adolescent psychiatry ground rounds. And we want to thank L3, or the Office of Lifelong Learning, of the Faculty of Medicine and Dentistry of the University of Alberta for providing much of the logistical and technical supports for these rounds. And we also want to acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So a reminder regarding webinar housekeeping: please use the chat feature if you have questions about the technical issues with these rounds. And if you have a question for the speaker, please use the Q&A feature. And of course, you can upvote questions that you would like to be answered. And Dr. Knowles has kindly agreed to stay on till 12:15 if needed, if there are more questions. So yeah, Dr. Jake Knowles is doing these rounds, which is providing an update from DSM-5 to DSM-5-TR. So Dr. Knowles is a PGY4 psychiatry resident at the U of A, so one of our own. He had the pleasure of completing all of his education in his hometown of Edmonton, completing undergraduate studies in biology and chemistry, followed by medical school, followed by psychiatry residency. And so he is one of our entering child and adolescent psychiatry subspecialty residents, and will begin his subspecialty training at the U of A in July. We really appreciate that Dr. Knowles has stepped up to present on this topic that was requested by CAP Grand Rounds attendees. So take it away, Dr. Knowles.
Thank you very much, Dr. Liang. I'll just share my screen quickly. Okay, so the topic of my presentation, I'm just gonna fix my screen here, is providing an update from the DSM-5 to DSM-5-TR, like Dr. Liang had mentioned. And along with many things that I've learned during my creation of this topic, I was actually able to learn also that the DSM-5 is spelled with a 5 instead of the Roman numeral 5, which was something that I had incorrectly assumed previously. A little bit about myself. I'm a psychiatry PGY4 at the University of Alberta, like Dr. Liang had mentioned, and I'm also entering my subspecialty training in child and adolescent psychiatry in July. I don't really have any significant disclosures to make at my level of training, but I will say that I'm an employee of Alberta Health Services and a resident with the University of Alberta. This presentation has received no financial support or support of any other type. There are no specific conflicts of interest, and I have no relationship with the APA. And as a result, there were no specific sources of bias that I were able to identify, and as a result, no specific mitigating steps needed to be taken. My objectives of today's talk are to provide an overview of some of the global changes that were made to the DSM-5-TR, as well as outline and provide the criteria for some of the new diagnoses present in the new edition, to explore and explain high-yield changes to existing diagnoses for child and adolescent psychiatry. And then I also want to provide a brief outline of some of the additional changes that are present in the DSM-5-TR that are not very relevant to child and adolescent psychiatrists, but I still think for the sake of completion, it's important to outline some of those. All of the information for today's talks was taken from the DSM-5-TR fact sheets, which are available on the APA website, as long as as well as the actual DSM-5 and DSM-5-TR. So there is a good website that provides summary sheets for all the changes that were made. However, it's important to acknowledge that some of the changes that were made, they don't actually have the new text that is in the DSM-5-TR present in the fact sheets. They'll explain what the change was and why it was made, but don't actually explain the wording. So in my presentation today, I will try to, where it's relevant, provide the new wording, just so everybody is up to date. In terms of why I have chosen to do this topic for my grand rounds today, probably the primary reason is I was reached out to and it was explained that this is a highly requested topic for the child and adolescent psychiatry grand rounds. But a couple of the other reasons are right around the time I heard about this being a requested topic, we had an OSCE for our psychiatry program. And during that OSCE, the topics were all on the changes for the DSM-5-TR. So some of the new diagnoses like prolonged grief disorder and some of the changes in names of diagnoses. And I had realized I wasn't fully up to date. And this was a really good opportunity for me to get up to date, but also provide some information to others, learners or otherwise, that may be like craving this kind of information to help themselves get up to date. And then another reason, and this was more self-serving, is I also had an adult psychiatry grand rounds coming up that I did back in April. And it was a good opportunity for me to do a similar topic for them as well. So I gave them a shorter version of this presentation. So the first objective is to provide an overview of some of the global changes to the DSM-5-TR. So the first thing I wanted to go over is the development of the DSM-5-TR. So development began in the spring of 2019, and they had 200 subject experts, over 200 subject experts, with backgrounds that spanned a significant amount of clinical work, including psychiatry, psychology, social work, pediatrics, etc. I think an important thing to highlight is they provided a graph here, or a chart that shows the difference in the different clinicians that I guess consulted on the DSM-5 and then consulted on the DSM-5-TR. And you'll notice that there's a significant increase in the amount of other health professionals that have, I guess, had some say in the development of the DSM-5-TR. I think this is important to highlight because practitioners other than psychiatrists and psychologists do use the DSM-5-TR in their clinical work, including like nursing staff in emergency rooms or on psychiatric units. And it's important to get that input when developing these sorts of documents. There were also changes that were made specifically to attend to culture, racism, and discrimination. And I'll highlight some of these now. So the term racialized is used instead of race and racial to highlight the socially constructed nature of race. The term ethno-racial is used in the text to denote some of the census categories in the United States, such as Hispanic, white, or African American. The term minority, as well as the term non-white, are avoided because they describe social groups and ethnicities specifically in relation to the racialized majority, which would be Caucasian typically, which would perpetuate social hierarchies. The term Latinx is used instead of the genderized kind of names Latino and Latina. The term Caucasian is not used as it's obsolete and it doesn't entirely encapsulate some of the geographic geographic origins of people from Europe. Caucasian was a catch-all term, and when we're looking at actual epidemiology, this doesn't really show exactly where people are from. For example, people from Ukraine are not necessarily genetically related to people from the UK, and it would not capture that by using the term Caucasian to describe both ethnicities. Prevalence data on specific ethno-racial groups were also included where they were able to get reliable estimates. There were also changes made to Section 3 of the DSM, and this section is the area where they provide assessment measures such as psychosis scales, etc. And some of the changes made in this section were that all the male and female text boxes were removed. Psychosis symptom severity scale was edited to be more consistent with the criteria of psychosis. And the World Health Organization Disability Assessment Schedule 2.0 added some clarification on how to score. And then there were also changes to the cultural context section, which included revisions to examples of the cultural context of distress. And this was to remove stigmatizing language. So those were the global changes that were made. Now I want to outline and provide the criteria for the new diagnoses that are present in the DSM-5-TR. So here is the list of the actual fact sheets that are all present on the website that I had talked about earlier. I will try to touch on all of them today, although I'll try to keep it relevant. So some of the less relevant ones, I'll be more brief. The big new diagnosis that has been added to the DSM-5-TR is prolonged grief disorder. So this diagnosis has been added to the trauma and stressor related disorders chapter. This was the evolution of a previous diagnosis that was listed for further study, and that was prolonged complex bereavement disorder, as some people might remember. And it's something that I've actually seen diagnosed over the last few years, even though it was not listed as a full diagnosis yet in the DSM-5. The criteria for prolonged grief disorder are quite lengthy. I'm going to go over them now, but I do have a slide in a little bit that tries to summarize the criteria to make them easier to remember. So criteria A is the death of the loved one was at least 12 months prior to the development or the assessment. In children and adolescents, the death had to have been 6 months previously, so half the amount of time. Since the death, there's been the development of a persistent grief response, and this is characterized by intense yearning or longing for the deceased person, and preoccupation with thoughts or memories of the deceased person. And in children and adolescents, the preoccupation may focus on the circumstances of the death, such as how the person had died. The criteria C is a list of symptoms. So since the death, at least 3 of the following symptoms have been present for most days to a clinically significant degree, and they have to have occurred nearly every day for at least the last month. So these criteria are identity disruption, marked sense of disbelief about the death, avoidance of reminders that the person is dead, and in children and adolescents, this may be characterized by efforts to avoid reminders, intense emotional pain related to the death, difficulty reintegrating into one's relationships and activities after the death, emotional numbness, and feeling that life is meaningless as a result of the death, and then also intense loneliness as a result of the death. Criteria D is the disturbance causes clinically significant distress, which is present in most of our diagnoses in the DSM. Criteria E is the duration and severity of the bereavement reaction is clearly exceeding expected social, cultural, or religious norms for the individual. And criteria F is the symptoms are not better explained by another mental disorder, such as major depressive disorder or post-traumatic stress disorder. I'm going to touch on that in a little bit as well. So here's my simplified way of remembering the criteria for prolonged grief disorder. So the death of the loved one has to be more than 12 months, and in child and adolescence, it's actually 6 months. Struggling with thoughts of or learning for the loved one, and memories of the loved one. And then 3 of the following symptoms: identity disruption, disbelief about death, avoidance of reminders, intense emotional pain, difficulties in reintegrating into life, emotional numbness, feeling life is meaningless, loneliness. And then the symptoms have to cause clinically significant distress. It has to be not in keeping with the patient's culture or religious context, and has to not be better explained by another mental disorder. If anybody is able to come up with a good acronym for these criteria, I would really appreciate it, and you can reach out because they are quite long, and I think with practice it'll be easier to remember, but I think in the short term would be helpful. A common question, and one that came up during my presentation with for general adult grand rounds, was can prolonged grief disorder be diagnosed with MDD? And the reason this question is there is if you look at the criteria F is not better explained by another mental disorder, and it specifically identifies major depressive disorder as something that could not better explain the symptoms. So I did look into this a little bit further. And it specifies in the DSM that yes, you can diagnose them and they can be comorbid conditions. I think the important thing and the reason that specifier is, or it's specified in criteria F that the symptoms are not better explained by major depressive disorder, as if you do a brief overview of the patient's symptoms, you'll see that lots of the symptoms actually do overlap. The patient might be struggling with anhedonia, they might be struggling with an altered mood, there might not be spending time with loved ones as much and isolating, and all these symptoms can be present in both prolonged grief disorder and major depressive disorder. So I think the DSM criteria are specifically trying to make sure people just take a look and be sure that what they're diagnosing is specifically due to the grief of losing the loved one and not due to a major depressive disorder. In addition, sometimes people have a premorbid or a diagnosis of major depressive disorder prior to the loss of the loved one. And in that case, if they suddenly develop symptoms of prolonged grief disorder following the death of a loved one, you could diagnose that as well. Another new diagnosis to the DSM-5-TR, and this might be surprising to some people, is unspecified mood disorder. This is a disorder that I've seen diagnosed many times, as it was in the DSM-4. However, when they split up bipolar disorder and depressive disorders into separate categories instead of a mood disorders chapter, they actually did not include an unspecified mood disorder. And what they've found is at times during a single cross-sectional assessment, it might be difficult to differentiate between a bipolar disorder or a depressive disorder, especially if the patient is not in a manic phase. And as a result, they've added this diagnosis back in, so it can be given to patients who you don't quite know which category they actually sit in. Another added diagnosis is suicidal behavior and non-suicidal self-injury. These are codes that have been added to the other conditions that may be a focus of clinical attention section. And the primary reason for adding this was for the purposes of research in terms of like statistical analysis and things like that. If the patient is coded to have suicidal behavior and non-suicidal self-injury, it will be easier to do retrospective studies. Another new diagnosis is olfactory reference disorder. This was actually previously present in the DSM-5 under the name Jikoshu Kyofu, and I apologize if I am butchering that pronunciation. This is a term that's used in Japanese psychiatry. Unfortunately, they found that the use of this term incorrectly led to the assumption that it was a cultural phenomenon, somewhat like some of the other cultural diagnoses that are listed in the DSM, like amok. But this has been described around the world, and it's not strictly limited to Japanese psychiatry. As a result, they've changed the name to olfactory reference disorder, which aligns with the newly added diagnosis in the ICD-11. And this diagnosis is given as one of the other specified obsessive compulsive and related disorders. So here is the actual listing in the DSM-5-TR for olfactory reference disorder, or olfactory reference syndrome, which it can also be called. It's a persistent preoccupation with the belief that one emits a foul or offensive body odor that is not unnoticeable, or that is unnoticeable to others. In response to this preoccupation, they engage in obsessive or kind of compulsive symptoms, such as excessive showering, seeking reassurance, and attempts to camouflage the odor. And they cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So the next objective for my talk today is I want to explore and explain the high yield changes to some of the existing diagnoses for child and adolescent psychiatry. So the first disorder that has had a wording change that is quite relevant to child and adolescent psychiatry is autism spectrum disorder. So previously in criterion A, the text read as manifested by the following. And this could lead to some confusion where people thought that only one or two of the three symptoms were needed to make the diagnosis. So the change was made to update the text to as manifested by all of the following. And I show that here. So in criterion A, as you can see, it says persistent deficits in social communication and social interaction across multiple contexts. And it previously said, as shown by the following, and then they listed these three different contexts. So deficits in social emotional reciprocity, deficits in nonverbal communicative behaviors, and deficits in developing, maintaining, and understanding relationships. Now they've just added as by all of the following, indicating that they need to have all three of the criteria met, which may change how some people practice. It was one concern they had with the old wording. The next diagnosis that has been updated is intellectual developmental disorder or intellectual disability. The primary change to this one was actually the name. So it previously was called intellectual disability. However, they renamed it to be more in keeping with the ICD-11. So now it's intellectual developmental disorder. They actually still use the term intellectual disability, and it remains in brackets, similar to how in the past, and we'll get to this, but in the past, social phobia was present for social anxiety disorder, or dysthymia was present for persistent depressive disorder. There were also some mild changes to text clarity, but I'm not going to go over those here as they're primarily just wording changes and not content changes. In terms of gender dysphoria, the wording throughout the text was updated to use more neutral language. For example, desired gender was changed to experienced gender, natal male was changed to individual assigned male at birth, and cross-sex treatments were changed to gender-affirming treatments. And these changes were somewhat in keeping with those cultural changes that I made reference to in the global changes section of my talk. A change that was actually specific for child and adolescent psychiatry was a change to PTSD. In children, the phrase witnessing does not include events that are witnessed only in electronic media, television, movies, or pictures, was completely removed. And this is due to the previous point in the criteria indicating that the trauma had to have occurred to trauma occurring to other people must occur in person or be witnessed in person. So I just put the text at the bottom here, witnessing in person the events as it occurs to others, especially primary caregivers. So this is what was actually already present in the DSM-5, but then the point after it indicated that it could not be in electronic media, which did not make a lot of sense. Bipolar 1 and 2 disorders had actually some of the most revision out of any of the disorders in the DSM-5-TR. So the criteria excluding psychotic illness was completely revised to be more consistent with how the criteria previously read in the DSM-4. So if you remember, there's that one criteria, and I'm going to go over it in a second, that specifies that you cannot diagnose bipolar disorder if there's a diagnosis of schizoaffective disorder, schizophrenia, etc. So they've revised that. There was a revision of the mood congruent psychotic features specifier to include mood congruent psychotic features with depressive episodes as well as manic episodes. And there was also a change to the severity specifiers for mania, as it was previously impossible for a manic episode to be considered mild based on the previous specifiers. So here's the example of the old criteria that was excluding psychotic illness. So for bipolar 1, it had read that the occurrence of the manic and major depressive episodes are not better explained by the psychotic illnesses, essentially. So schizoaffective disorder, schizophrenia, schizophreniform, delusional, or other specified. Bipolar 2 had a very similar criteria, but it was criteria C. So the change to the criteria is listed here. So it specifies that at least one manic episode is not better explained by schizoaffective disorder. And that's because psychotic features are actually present in the criteria for schizoaffective disorder. And so it makes sense to have that being exclusive. However, they've added that it is not superimposed on schizophrenia, schizophreniform disorder, delusional disorder, or other specified or unspecified schizophrenia spectrum or other psychotic disorder. So they've just slightly changed that wording so that it makes more sense diagnostically. They've also changed the mania specifiers, as I've said. So the new mania specifiers are mild is the minimum symptom criteria are met for a manic episode, moderate, very significant increase in activity or impairment in judgment, and severe is almost continual supervision is required in order to prevent harm. So for severe and moderate, they're mostly the same. Severe, you'd likely need a locked unit, etc. For mild, they've changed it, as previously it had mentioned level of functioning, but for the diagnosis of mild mania, you wouldn't have to, or you wouldn't be able to have functioning still. One of the criteria for mania is actually that there's significant change in the patient's level of functioning. So this change actually makes more sense. Disruptive mood dysregulation disorder has also been updated. So the text in the development and course section was just slightly changed. This is a very small change compared to some of the other diagnoses. So in the actual criteria for this disorder, the age range is no younger than 6 and no older than 18. But in the development and course section, they had listed the ages as 7 to 18, and now they've updated it to read 6 to 18. Major depressive disorder had a similar change to bipolar disorder. So criterion D indicated that you could not diagnose major depressive disorder if it's better explained by one of the psychotic illnesses, such as schizoaffective disorder, schizophrenia, or schizophreniform disorder. So they've made a very similar change to bipolar disorder, where at least one major depressive disorder or episode is not better explained by schizoaffective disorder, and it is not superimposed on the other psychotic illnesses. And again, this is because mood symptoms are not present in the psychotic illness diagnoses, so it's difficult to actually exclude it. Persistent depressive disorder had a mild change. I had mentioned before how intellectual disability has remained in brackets. However, dysthymia had previously remained in brackets, but it's now been removed completely from the text of persistent depressive disorder. The reason this change was made is previously in the DSM-4, if somebody was being diagnosed with dysthymia, it would not be possible to diagnose somebody with a major depressive episode at the same time. If somebody was suffering from a major depressive episode or major depressive disorder, they actually did not have persistent depressive disorder or dysthymia. With the diagnosis of persistent depressive disorder, it's actually possible to meet the criteria for a major depressive episode at the same time, and there's actually specifiers for persistent depressive disorder indicating that the criteria for major depressive disorder have been met. So this term has been removed as it's no longer accurate with the criteria of persistent depressive disorder. Other specified depressive disorder has also had a new example added. So this was added due to the changes to major depressive disorder and that criterion D. So now if somebody has a major depressive episode that is superimposed on schizophrenia, schizophreniform disorder, delusional disorder, or any other psychotic illness, the proper diagnosis would be an other specified depressive disorder with a major depressive episode superimposed on that diagnosis. If a major depressive episode is part of a schizoaffective disorder, it would not merit an additional diagnosis. So it would be appropriate to still diagnose schizoaffective disorder. And then there's also a change to other specified feeding disorder. Specifically, this is a change to atypical anorexia. There was a phrase added to it. Individuals with atypical anorexia nervosa may experience many of the physiological complications associated with anorexia nervosa. This just is to clarify that even if somebody has, let's say, electrolyte disturbances, ECG changes, etc., that are often present in anorexia nervosa, it would not actually necessitate the diagnosis of anorexia nervosa without the disruption in weight. So for anorexia nervosa, it still remains that a patient needs to be significantly underweight to make that diagnosis. And so if somebody has atypical features and maintains a normal weight while still having these electrolyte disturbances, it might be due to purging or just or poor intake, you can still diagnose atypical anorexia nervosa. Avoidant and restrictive food intake disorder is another eating disorder that has been updated. The phrase "as manifested by persistent failure to meet appropriate nutritional and/or energy needs" has been completely removed from the first criteria. And this is a little bit confusing, so I did put the actual criteria here on the next slide. So an eating or feeding disturbance, apparent lack or interest in eating food, avoidance based on sensory characteristics, etc., as manifested by persistent failure to meet appropriate nutritional or energy needs. That phrase did not make a lot of sense. As if you look at the 4 criteria actually listed, the 4th criteria is marked interference with psychosocial functioning, and I have that in bold there. Marked interference with psychosocial functioning has nothing to do necessarily with persistent failure to meet appropriate nutritional or energy needs. As a result, by saying that these 4 symptoms are associated with the failure to meet appropriate energy needs, it wasn't clear. It didn't make a lot of sense. By removing that phrase, they've actually not changed the criteria at all, but they've made the criteria actually just make more sense, as the first 3 criteria, significant weight loss, significant nutritional deficiency, and dependence on enteral feeding, all completely make sense with persistent failure to meet appropriate nutritional or energy needs. A small change, but this is important for our consult liaison colleagues. Functional neurological symptom disorder is the new name for conversion disorder. And the reason this was renamed is conversion disorder was beginning to get some stigma, and the diagnosis was more difficult to make. And functional neurological symptom disorder also coincides with some of the terms used by our neurology colleagues when they're making these sorts of diagnoses. Social anxiety disorder was also renamed. As mentioned before, social phobia was previously in brackets beside the name, and this has been removed from the name of the disorder completely. And now I want to just provide a brief outline of the additional changes to DSM-5-TR. These changes are either not highly relevant to child and adolescent psychiatry, except in specific contexts, or the changes were very mild and they're not in disorders that are regularly diagnosed. So I wanted to just put them in the last section. So one change was made to attenuated psychosis syndrome. The text was modified to improve clarity. Essentially, the phrase "with relatively intact reality testing" was removed. This was largely inconsistent, as you can't have relatively intact reality testing if you also have a delusion, as it's a fixed false belief. Bipolar and related disorder due to another medical condition and depressive disorder due to another medical condition had a fairly minor but significant change at the same time. So there was a small change made to the wording of criteria A for both of these diagnoses. Previously, these diagnoses were under the mood disorders chapter in the DSM-4, and they were written consistent with bipolar and related disorder due to another medical condition, substance-induced bipolar and related disorder, depressive disorder due to another medical condition, and substance-induced depressive disorder. All of these diagnoses had essentially the same wording in criteria A. When they split up the sections, some of the wording became unclear, and so it was minorly reworded to make it more consistent. I'm going to show an example here. And I will say the same change was made to the substance-induced bipolar and depressive disorders as well. So previously in the DSM-5, you can see that in the bipolar related disorder due to another medical condition and the substance-induced bipolar related disorder had a fairly different criterion A. Specifically, it had said that the prominent and persistent disturbance occurs with or without depressed mood. And that term was not actually present in bipolar and related disorder due to another medical condition. So what they've done with all 4 of these diagnoses is simply consolidated them all to the same format for criteria A to make them very clear that it's a prominent and persistent disturbance in mood. It predominates the clinical picture and is characterized by, from bipolar disorders, the abnormally elevated or expansive or irritable mood. And then for the depressive disorders, they specify that it is a low or depressed mood. There was a small change to narcolepsy, and this is that the subtypes of narcolepsy were revised to better mesh with the International Classification of Sleep Disorders, 3rd edition. Delirium had a change as well. So in criterion A, a disturbance in attention and awareness was essentially revised to mean the same thing. However, they took out that second bracket. So previously it said awareness bracket, reduced orientation to the environment, and awareness and orientation to the environment technically don't mean the same thing. So now they have updated that to accompanied by reduced awareness of the environment as a more simple statement. There also has been a change to the subsyndromal delirium in the other specified delirium disorder part of the DSM. So first of all, the term attenuated delirium was changed to subsyndromal delirium. And I just put the criteria there, or the actual description of subsyndromal delirium, but it's essentially a delirium-like presentation that does not fall within the full severity of a delirium that can be diagnosed based on the criteria in the DSM-5-TR. Other specified bipolar and related disorder had a third example added to a reason to diagnose this. And this was a hypomanic episode without prior major depressive episode. So if you remember, for bipolar 2 disorder to be diagnosed, somebody needs to also have had previous, they've had to have had major depressive episodes and hypomania episodes. So if somebody has not had that depressive episode, this is the diagnosis that should be given. Other specified schizophrenia spectrum and other psychotic disorder has been updated as well. And this was specifically for the 4th example of this diagnosis that is in the DSM. So the 4th example is essentially folie à deux. They've changed the wording to take out the term partner. Previously, with the word partner, it somewhat implies that there's a romantic relationship with the person who is struggling with the the second person with psychotic symptoms. So now it specifically states delusional symptoms in the context of a relationship with an individual with psychotic delusions. And this relationship can be of any type. It does not need to be romantic. So here's just a review of the objectives that I had wanted to accomplish today. I wanted to provide the global changes, outline and provide the criteria for the new diagnoses that are present, explore, and so really that only is prolonged grief disorder is the primary one. Explore and explain high-yield changes to the existing diagnoses for child and adolescent psychiatry. Then just provide a brief outline of some of the additional changes that have a little bit less clinical relevance or are diagnosed less frequently. I know that I'm ending a little bit early, and I knew that would be the case. There's not a lot of changes that are made to the DSM-5-TR. The majority of the diagnoses are either untouched or the changes were relatively mild. In conclusion, the DSM-5-TR represents a change to DSM-5. The primary changes were the addition of prolonged grief disorder and the re-addition, I guess I should say, of unspecified mood disorder, as this is a very commonly given diagnosis. Revised names of conversion disorder and social anxiety disorder. The changing of wording in multiple diagnoses, primarily for the reasons of either being more culturally appropriate or to provide language that is more clear in terms of making the diagnosis. For child and adolescent psychiatry specifically, the most salient points were the addition of prolonged grief disorder. And the important thing to remember is for the timeline, it's only 6 months instead of 12 months like adult psychiatry would diagnose. The change in wording for autism spectrum disorder and intellectual disability, updated language for gender dysphoria, as well as a change in name for conversion disorder. And then there's also a change to the PTSD criteria for childhood exposure to trauma. There actually wasn't a large change to the criteria themselves, but they did remove the phrase that it could not be in electronic media because the other points had indicated that the exposure to other people had to be in person and witnessed. So the references for my talk were simply the DSM-5, DSM-5-TR, as well as the DSM-5-TR fact sheets, which are all available on the website for the APA. And they're a good reference for anybody who's interested. And I'll open it up for questions a little bit early. And I guess I'll let Dr. Leung do her part that she needs to do as well.
Sure. Thank you so much, Dr. Knowles, for this very clear, useful, and relevant presentation on the DSM-5-TR, changes and updates. And I certainly learned stuff during the presentation, and I hear from Dr. Van Riper, or actually Dr. Lemieux, that this was a really helpful overview of changes in the DSM. So definitely we use DSM quite a bit. So we appreciate that you did this. So before we move on to the questions, just as a reminder for people that these rounds are accredited by both the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians of Canada, and up to 0.25 hours under Section 1 for the Royal College, and up to 1.25 main pro plus credits for the College of Family Physicians. And also for those of you who need to leave a bit earlier, before the Q&A, a reminder to fill out the evaluation. And by the way, I want to let people know that a fairly high number of people actually did our annual evaluation, and which we're really thankful. So our CAP Grand Rounds Committee definitely reviewed all of the feedback that was provided to continually improve our Grand Rounds. And we appreciate if people per session could provide the evaluation as well. So yeah, we appreciate all of the feedback that you provide. So moving on to the Q&A, I don't see questions yet, but I have a question, and people can have maybe a bit of time to add these. So I struggle a bit with the use of unspecified versus other specified determination when using it with various criteria. And I know that you've given some examples, let's say for anorexia, that they, maybe, meet, some of the criteria of anorexia with regard to physical, but not regarding some of the maybe mental, psychological. And so do you find, in the literature, do people actually do that? Like, instead of just saying unspecified, that they would actually go with other specified, and this is the reason I didn't diagnose with the typical diagnosis.
I haven't seen it come up, honestly, like reading literature. People typically don't use the other specified as much. And I think that's part of the reason for having the other specified is there isn't necessarily a lot of research on some of these topics or these diagnoses. Like for OCD, we have the olfactory reference disorder and the other specified. And I think it's there as it's a phenomenon that's been witnessed, and lots of psychiatrists in Japan and in other areas of the world have seen this diagnosis and people struggling with this very specific thing, but they don't quite meet the criteria for OCD maybe. So they need something that they can diagnose the patient with, and you could just call it like a unspecified obsessive and compulsive related disorder. But when you do that, I feel like it doesn't fully paint the picture for the person looking at that diagnosis for what the patient's struggling with. Um, so I think the kind of other specified diagnosis is kind of reserved for those specific things that people have anecdotally seen enough to like write case reports on or things like that, but not necessarily enough to have its own separate diagnosis given.
Mhm.
Um, but it's like common enough. So like for atypical anorexia nervosa, um, it's the diagnosis given for people who essentially have all the symptoms of anorexia nervosa, but don't have the low weight. And that could be for a number of reasons. They could have been um, unfortunately overweight beforehand and just haven't got that threshold or what have you. So then you can give that diagnosis instead. And that's where the confusion was when in that diagnosis is let's say the person was overweight before, had been doing all the behaviors, all the symptoms of anorexia nervosa, and had lost weight, but still wasn't to that point where they met the threshold of, of the BMI. Um, and then they had metabolic derangements because of that. Maybe they were purging or things like that. People would then not know what to diagnose. It's like, well, they clearly have anorexia, but not quite based on the definition. So I think that's kind of what it's limited for, is those like more rare disorders that still have some literature, maybe not a lot of literature, and it's a specific diagnosis that can be given. The same thing would be true for like that, which one was it? Other specified depressive disorder, where it's major depressive disorder or episode that is superimposed on some of the psychotic illness. And the reason that's there is people with schizophrenia do get depression, and that doesn't mean that they always have schizoaffective disorder, but that also in major depressive disorder, it specifically states that it can't be explained by schizophrenia. So there needed to be some sort of diagnosis that could be given in that case.
Yeah, that's that response, that you provided makes a lot of sense. That sometimes there's almost these like subcategories
Mhm.
that especially people in the field are familiar with, but then it just doesn't sort of fit like the typical.
Yeah.
But you still maybe want to highlight it as, like you say, some literature and evidence
Mhm.
backing that up.
Yeah. It's
Okay,
tricky.
so
It's trying to fit everybody into specific boxes, but not every patient is going to have symptoms that perfectly align with the actual criteria in the DSM. So it gives us a little bit of flexibility.
absolutely. So we do have some questions coming in. So the next question is, the prolonged grief disorder is specific to people, and then any wording that would allow for a diagnosis in response to a loss of a pet.
I didn't come across that when reading it. Like my reading was that it would be specific to the loss of people. It is a new diagnosis, and I think if you're seeing somebody who like would meet the criteria fully, and it's been like I guess in child and adolescent psychiatry, 6 months since the loss of a pet, and it's that functionally limiting, I think I would still treat it like I was treating a prolonged grief disorder, because I don't know what else you would treat it as necessarily. I think the actual like DSM is meant to specify that, like I shouldn't speak to what they meant to do because I wasn't part of those meetings. But my understanding is that it's meant to be the a loss of a loved one or a person that they're close to. But I could definitely see somebody having similar symptoms of the loss of a pet. So I would probably just err on treating it like prolonged grief disorder in that case.
Yeah, actually, I think that's a wonderful comment and question, Ricardo. I think that you should be writing to the DSM committee and asking them to like clarify, because yeah, we do see that for some people, their pet is their family, and so being able to widen that diagnosis, or to be inclusive would definitely. So let the DSM people know. So another question is, I always assume delirium related to more acute or medical situations. However, I see many children in the context of childhood trauma who have significant events in school where cognition and learning plummets, and with no sustained focus, and they often do complain of hallucinations. So we describe this as a dissociation, but with the DSM-5 criteria for delirium fit here, And if so, what is the best management for this?
So for delirium in the DSM-5, there has to be typically that acute medical cause for the change in cognition or the change in attention. So I don't think the diagnosis of delirium would fit there. I think that like it would fit more with that dissociation, but I think it's important to think about the reason. Like that's a very good question. It's important to think about the reasons for this like plummet in attention and focus and hallucinations. Like dissociation in general is a very interesting response to trauma, and I think it definitely needs to be kind of looked into more about why that's happening, especially when you're getting those functional changes, like if somebody's struggling at school suddenly and they've had this trauma, why is that the case? But I don't think it would, delirium itself, that diagnosis would not fit with it.
Yeah, that makes sense because delirium is more tied to like the medical, condition. And I mean, end up using unspecified trauma and stressor related
I
disorder
use that a
a
lot
lot.
as well.
Yeah, because honestly, DSM is actually not very good for childhood trauma. And I know developmental trauma disorder was somewhat didn't meet threshold of being included in DSM way back when. But because a lot of kids don't exactly meet PTSD as it's defined, but we see them obviously as being affected by traumatic experiences.
And I definitely see this as an area where things like complex PTSD and things like that, which I know are somewhat controversial in some circles, but I think we're trying to describe phenomenon with these labels that are very difficult and these criteria that are difficult to use. But I think overseas, they're using complex PTSD a little bit more now. And that might be something that the DSM is, I guess, looking into for DSM-6. I don't have any inside information, but
Yeah, reconciling, because I think
looking at
complex
that.
trauma disorder and ICD, is it 11 that they're at now?
I think so. Yeah, they're at 11.
Yeah. But it seems like they are trying to move. You've even given some examples of sort of the diagnoses being more compatible. So a work in progress. So Dr. Van Riper. Oh, she thought of an acronym,
Yep.
it sounds like. So
Great.
thanks for the excellent and clear presentation, Jake. Yay. And for the acronym challenge, apparently Dr. Van Riper loves making acronyms. So she has, okay, you're going to think of 3 little reminders. So L equals intense loneliness. R equals reminders the person is dead and avoidance of reminders. E, emotional pain is intense. M, life is meaningless. I, identity disruption. N, numbness. D, deep belief about a person's death is marked. And R, problems reintegrating into relationships and activities. Wow, great
That's really
acronym.
good.
You have a
Yep.
very creative brain. I certainly
Yep.
couldn't listen to ground rounds and think about making an acronym
We'll have to
at
save
the
that
same
for roll
time.
call studying.
Exactly, like you need to take a screenshot. Okay. So yeah, and I guess maybe I had one last question, which is this idea of polysubstance use, because I think anecdotally, like because sometimes with kids it is like they're also a work in progress. So their substance use is also fluctuating and variable. So maybe they do have like, nicotine disorder at this point in time, and then alcohol use disorder, another, and then and they're trying different things. And so we end up with like, a kid at a point in time might have these 3 substance use disorders, at a different time maybe these 2, and then add another one. And whereas polysubstance, kind of seems to capture, but I guess in DSM-5-TR, there's no good, I guess, diagnosis that would be more sort of like lumping things in.
I think that's like very reasonable. I think The DSM-5, while it's a very, very good tool, especially for learners, like learning the categories of things, learning common symptoms that people have, learning how to kind of differentiate these in psychiatric interview. There are limitations in trying to have all the patients fall into certain boxes. So yeah, like a good point would be somebody experimenting actively with multiple substances and kind of using whatever they can get their hands on. Sometimes you see
Yeah.
because peers are using different things. Um, and I think in those cases, while having a DSM diagnosis is helpful for like coding purposes, research purposes, clinically, sometimes it just makes sense to diagnose like a polysubstance use disorder, or I've been on CL lately and I've definitely diagnosed like a normal reaction to like emotional stressors or things like that, like which is not a DSM
Yeah,
diagnosis at all, but I think
exactly.
it is a better contextualization of what is actually going on for that patient than calling it an adjustment disorder just for having a diagnosis. Um, so I think that's where I'd probably, if that's the experience of the patient, is they're just using all these substances and is constantly in flux. And every time you're seeing them, you're having to update your diagnosis list to whatever they used the last few weeks. I think I would just call it a polysubstance use disorder. And assuming you're not using that patient for research purposes or something like that, I think it would be very reasonable.
Yeah, yeah, that also makes a lot of sense that there's a practical basis in terms of how we use these diagnoses in our day-to-day clinical situation, as opposed to what you need for let's say a research
Mhm.
study, and being able to differentiate. So yeah, that's great response. So yeah, I think this is the end of the Q&A. And so just to remind people, grand rounds, we don't have them over the summer, but they will start up again in September at the same time. So the third Tuesday of the month from 11 to noon, or 12:15. So have a wonderful summer, and we hope to see you in the fall.